Good evening everyone. If I'm audible and visible, please send your thumbs up in chat box. If I'm audible and visible, please send your thumbs up in the chat box. Nikul, Dr. Roopshri, Arunava Datta. Okay, I'm audible. Right guys? Okay. So Unacademy is launching many products for NEET PG. Bigger savings are unlocked. You can get 25% off on all Unacademy subscriptions. So target next or NEET. Duration is of 6 months. And the offer price is 14,344. And for FMG 2023 rapid revision, the duration is 2 months and the offer price is only 4,500. So for subscription, you can use my code Dr. Pritesh. Unacademy is presenting NEET PG Vitals, in which you will get recorded videos for comprehensive NEET PG preparation, and you can subscribe this course also. There will be 800 plus hours of comprehensive recorded classes for all 19 subjects. Exclusive content is curated by expert faculties of NEET PG. It comprises of clinical based questions, previous year questions and image based questions. ACE Next 23, NEET PG 24. Next Focused Ultimate Concise batch. This is having integrated subject approach. There will be 200 plus classes and 400 plus hours of lectures. These are covered in 6 months. It will be live on June 21st. You can get access to this batch at rupees 6,000 only, and for this also you can use my code Dr. Pritesh. FMG Final Frontier is there for FMGE July 2023, and this is available at Unacademy store. Duration is 1.5 months and total 100 plus hours are there. You can get this subscription in 2,999. You can use my code Dr. Pritesh for this subscription. Okay guys, so let's start now. So see the question. First question, match the following. Okay, so tell me what is the correct answer for this one. Peau d'orange. First you tell me peau d'orange. This is because of which condition? This is because of lymphatic permeation by tumor cells. After that, dimpling. What is the cause of dimpling? Dimpling, it is because of involvement of ligament of Cooper. Puckering. Puckering is also because of ligament of Cooper. And cancer in cuirass. This is because of involvement of breast, skin and chest wall. So what is the correct answer? 1B, 2A, 3A and 4C. Clear guys? So what is the correct answer? Khushbu, Tiny World, Lalu Pandey, Meet, Krishan Pal Singh Rathore. Very good. So what is the correct answer here? The correct answer is B, option number B. So you know that the peau d'orange, it is because of lymphatic obstruction or permeation by tumor cells. Both dimpling as well as puckering, it is because of involvement of ligament of Cooper. And cancer in cuirass, there are multiple nodules and ulceration because of involvement of breast, skin and chest wall. Okay guys, so correct answer is B. Now see this question and tell me what is the correct answer. Let me see who is going to reply first. Most probable malignancy that develops in case of long-standing goiter. Let me see. How many of you are going to mark the correct answer? First person, most probable malignancy that develops in a case of long-standing goiter. Brijesh, Roopshri, Tiny World, Khushbu Bloch. Tell me what is the correct answer. Yes guys? Shri. Shri is the first person to reply correctly. Tiny World, Roopshri, Brown, Traveler, Meet. All of you correct. Love Pandey, Brijesh Yadav. All of you are correct guys. So see, the follicular carcinoma, it develops in or it is seen in iodine deficient areas. And because of that iodine deficiency, what's the problem? Because of iodine deficiency, the patients are having goiter. So these patients are having long standing goiter. So the most common malignancy seen in long standing goiter, that is follicular carcinoma thyroid. All of you know that what is the most common type of thyroid malignancy? So most common type, that is papillary carcinoma. Anaplastic, it is seen in 7th to 8th decade. 7th to 8th decade, 70 to 80 years of age. And you know, medullary carcinoma thyroid, yes, it is associated with men 2A, 2B. The familial variant, it is associated with men 2A, 2B. So correct answer for this question is option A, that is follicular carcinoma. Now read this question guys and tell me what is the correct answer. Yes, see the question. 35 years old US citizen presented to OPD with abdominal pain and fever. Pain and fever. History of visit to India 3 months back. Ultrasound shows 5.5 into 3 into 4 centimeter cavity in right lobe of liver. Ultrasound finding is given below. Which of the following is appropriate treatment? So guys, first you tell me what is the diagnosis here. Humble, Vinodraj, Lakshmi, what is the diagnosis here? So all of you know here there is abdominal pain and there is fever. In the liver there is cavity. Actually this is abscess cavity. So this patient is having liver abscess. Now you tell me there is history of travel to endemic area, India. India is endemic area. In developing countries, because of fecal-oral route, there is increased risk of Entamoeba histolytica infection. So there is history of travel to India. That's why there is increased risk of this abscess. This is actually amoebic liver abscess. This is amoebic liver abscess. And all of you know that in amoebic liver abscess, what is the treatment of choice? We have to give oral metronidazole. But you also know that there are indications of aspiration. What are the indications of aspiration? Whenever the size of abscess cavity, it is more than 5 centimeter. It means if you see the 3-dimensional view, here you can see 5.5 into 3 centimeter into 4. So one dimension is more than 5 centimeter. It means what I have to do? I have to go for pigtail catheter insertion. So only oral metronidazole? No. Oral paromomycin? No. Laparotomy and drainage? No. Correct answer is what? Pigtail catheter insertion. Pigtail catheter insertion. So Sri, very good. Humble doctor, Love Pandey, the Varun Kashyap, these 3 people were correct. Khalid Ansari, you are also correct. So Khalid, you are also correct. So correct answer is C. Now guys, this is the latest question. It was asked in one of the latest exam. Tell me what is the correct answer. Best treatment for HER2 positive trastuzumab resistant breast cancer. Tell me what is the correct answer. Yes. Shri, very good. Positive bird, very good. Dr. Naruto, Dr. Brown Traveler, Varun Kashyap, very good guys, very good. Majority of you are correct. Majority of you are correct. Positive bird, very good. So this was asked in a latest exam. Let me tell you, in CA breast, see the important questions related to CA breast, important questions related to chemotherapy in CA breast. All of you know that in CA breast, what is the chemotherapy regimen we give? We give CAF. This is adriamycin based chemotherapy. Cyclophosphamide, adriamycin, 5-fluorouracil is given. So this is adriamycin based. All of you know. Some patients in whom there is resistance to adriamycin. So for adriamycin resistant breast cancer, you tell me which drug is given. Guys, tell me. For adriamycin resistant breast cancer, which drug is given? All of you know, taxanes. Taxanes. So what are those agents in taxanes? You know, this is docetaxel and there is paclitaxel. Okay guys, there is docetaxel and there is paclitaxel. Clear? Imagine there is resistance to both. adriamycin as well as taxane. So whenever there is resistance to both of these drugs, in that case what we give? Ixabepilone. We give ixabepilone, in which there is resistance to both adriamycin as well as taxanes. If HER2 new positive breast cancer is there, what is the first line agent? Trastuzumab. For HER2 new positive breast cancer, first line agent, that is trastuzumab. And the second line, this is the second line agent, that is lapatinib. Clear guys? What is the role of sunitinib? It is given for refractory and metastatic breast cancer. So what do you mean by refractory and metastatic breast cancer? The kind of breast cancer which is not responding to any other chemotherapy. So sunitinib, it is given to refractory and metastatic breast cancer. Clear guys? So all these are questions related to various chemotherapy agents used in CA breast. First line agent for HER2 new positive breast cancer, trastuzumab, also known as Herceptin, and the second line agent is lapatinib. So almost all of you were correct for this question. Correct answer is A, lapatinib. Okay guys, now tell me what is the correct answer for this question. Let me see who is going to reply correctly. 30 years old female, presents with diffuse thyroid swelling. TSH, it was elevated. Histopathological examination, intense lymphocytic infiltration and Hurdle cells. This is the clue. Hurdle cells. Tell me the diagnosis. Manisha Manju, Lakshmi, Krishan Pal Singh Rathore, Roopshri, Shri, Ankit Gujjar, Flame, RS, Naruto, Vinod Raj, Love Pandey, all of you are correct. Everybody is correct. This is a clear-cut question. What? It is Hashimoto's thyroiditis. You know what is the other name of Hashimoto's thyroiditis? This is also known as struma. This is also known as struma lymphomatosa. So here there is conversion of thyroid tissue into lymphoid tissue. So what happens? There is CD4 mediated CD8 cytotoxicity. It leads to permanent destruction of thyroid follicle and it leads to permanent hypothyroidism. So patient will be having signs and symptoms of hypothyroidism. If you perform FNAC, all of you know that there will be lymphocytic infiltration and characteristic cells. What are the characteristic cells? There is Hurdle cells, another cell Ashkenazi cells. So there is presence of Hurdle cells or Ashkenazi cells. Clear? In Hashimoto's thyroiditis. So Hurdle cells or Ashkenazi cells, and you know Hashimoto's thyroiditis, it leads to hypothyroidism. So what is the thyroid profile? Raised TSH, decreased T3, decreased T4. So all of you are correct. Dr. Ankit Gujjar want to tell us that anti-TPO is the autoantibody. You are correct. Correct answer for this question is B. Okay guys? Now tell me, easiest question, just on the basis of image, you can reply the question correctly. See the question. 45 years old male, presented with abdominal pain and hepatomegaly. Ultrasound image is given below. What is the diagnosis? Simple question. Munendra Singh, Brown Traveller, Manisha Manju, Khalid Ansari, Lakshmi, Pradyuman Patel, Naruto, Brijlal Yadav, Brijesh Yadav, Love Pandey, Tiny World. Everybody is correct. What is the name of this sign? Guys, what is the name of this sign? This is water lily, also known as water snake sign. Water lily or water snake sign. So it is going to, the scolex is going to, it is floating on the surface. So there is floating membrane sign, undulating membrane. This is known as water lily sign, and typically it is seen in hydatid cyst. It is seen in hydatid cyst. You know that in hydatid cyst, majority of patients are asymptomatic. Liver is filled with multiple cysts. So if patient is symptomatic, there is abdominal pain and liver is enlarged. So there is hepatomegaly. So correct answer is hydatid cyst. Why not amoebic liver abscess or pyogenic liver abscess? Because in the liver abscess, there is fever. In the liver abscess, there is fever. Fever is not there. In simple hepatic cyst, this is incidental diagnosis, usually asymptomatic. Okay guys. So simple hepatic cyst, it is incidental. Patient is asymptomatic. Clear? So correct answer for this question is A. Now see this question. MELD score doesn't include. Tell me what is the correct answer. Simplest question. MELD score. Which of the following is not the component? MELD score. Yes. Munendra Singh, Manisha Manju, Lakshmi Kaushal, Pradyumna Patel, Naruto, Humble, Muhammad Asif, Brown Traveler, Love Pandey. Everybody is correct. What? Blood urea. How to remember? It's very, very easy. MELD score, the mnemonic is CBI. Components are CBI. So full form creatinine, bilirubin. This is creatinine, bilirubin, INR. Okay. These are the three components. Can you tell me what is the full form of MELD score? Model for end stage liver disease. This is model for end stage liver disease. After that there is PELD score. PELD score. This is pediatric end stage liver disease. This is pediatric end stage liver disease. Okay. Can anybody tell me what are the components of PELD score? MELD score and PELD score, these are very, very important, asked frequently. Can anybody tell me what are the components of PELD score? How to remember? Mnemonic is NABIA. The mnemonic is NABIA. Okay. N, that is nutrition. Age, bilirubin, INR, and tell me clear guys? So nutrition, age, bilirubin, INR, albumin. These are the components of PELD score. So MELD score and PELD score, these are very, very important. Both of these are frequently asked in exam. Frequently. Both of these are frequently asked in exam. Clear? You have to remember. Now tell me what is the correct answer for this question. Very, very easy question. Some of the students, family members are having gallbladder polyp and they keep on asking that, sir, whether we should go for lap cholecystectomy or not. So see the question. 30 years old female, incidentally diagnosed with gallbladder polyp, size 0.5 centimeter. Patient was asymptomatic. Next step. Flame RS, Sri, Munendra Singh, Humble Doctor, Naruto, Vinod, Lakshmi, Tiny World, all of you are correct guys. First let me tell you what are the types of polyp in which there is increased risk of malignancy. First, the patient should be having which kind of polyp? Patient should be having adenomatous polyp. Clear? Because you know that adenomatous polyp, it's pre-malignant. Okay. So in which polyps there is increased risk of malignancy? Adenomatous polyp. First, age. If the age of patient is more than 60 years. Second, size. Size is more than 1 centimeter. Third, if there is presence of gallstones. And fourth, there is increase in size, unrepeated scan. So here you can see patient is young, size is less than 1 centimeter, 0.5, there is no symptom, there is no gallstone. So obviously what should be done? Lap chole not required, open cholecystectomy not required, CT not required. Correct answer is reassure the patient and follow up. So it is D. It's reassurance and follow up. Clear? Next question guys. This question was asked in almost each and every exam. FMG, NEET PG, AIMS, INICT, everywhere. Tell me what is the correct answer. I'm waiting for the reply. Let me see who is going to reply first. Let me see who is going to reply first. Yes. Manisha Manju, Ankit Gujjar, Naruto, Munendra Singh, almost all of you. It means your preparation is going on very nicely. Prabha Mishra, all of you are correct, guys. So Q SOFA, what is the full form of Q SOFA? Quick Sequential Organ Failure Assessment. Full form, it is quick. This is quick sequential organ failure assessment. So quick sequential organ failure assessment. Clear, guys? How to remember? It's very, very easy. There is a mnemonic. Mnemonic is QRSMS. Clear? Here Q means Q SOFA. R means respiratory rate. S, that is systolic blood pressure. MS, mental status alteration. MS, that is mental status alteration. So this is mental status alteration. Clear? How much should be the respiratory rate? Respiratory rate more than equal to 22 per minute. Systolic blood pressure more than equal to 100 mmHg. And there should be mental status alteration. In some of the exams, at the place of mental status alteration, you will find GCS or you will find neurological status. So 1 is the component, 2 is the component, 4 is the component, 3 is not the component. So 1, 2, 4, what is the correct answer here? Correct answer is B. And I am telling you, SIRS, Systemic Inflammatory Response Syndrome, Q SOFA, Bishop score, these are 3 very, very important scores. And we are expecting this in the exam. Clear? So this is expected in the exam. You have to remember Q SOFA, Bishop, SIRS, Systemic Inflammatory Response Syndrome. Okay, guys? Correct answer is B. Now, tell me, what is the correct answer? Which of the following is not true about pseudopancreatic cyst? Let me see who is going to reply correctly. Yes, I'm waiting for your reply. Guys, I'm waiting. Not true about pseudopancreatic cyst. Nobody till yet? Nobody? Waiting for your reply, guys. Waiting for your reply. Yes? Shri, first person to reply correctly. Shri. Tiny World. Love Pandey. Shri, Tiny World, Love Pandey. Prabha Mishra, Prabh Mishra, Shubham Sharma, Naruto, Krishan Pal Singh Rathore. Let me discuss pseudopancreatic cyst. See, there are 2 conditions. One is acute pancreatitis. So for acute pancreatitis, what is the most common cause? Gallstones followed by alcohol. All of you know that gallstone induced pancreatitis is having best prognosis. Why? Because gallstones are not going to cause permanent change in the pancreas. And second, we have curative treatment option available for gallstone induced pancreatitis. What? That if there is gallstone, we can perform lap cholecystectomy. So lap cholecystectomy is curative for gallstone induced pancreatitis. Alcoholic pancreatitis, what is the problem? It causes permanent changes. That's why the most common cause of pseudopancreatic cyst, it is not gallstone, it's alcohol. This is alcohol. Second, where the fluid is collected in acute pancreatitis. So guys, you know, the fluid in acute pancreatitis, it is collected in the lesser sac. And whenever this fluid is walled off by granulation tissue after 4 weeks, it is known as pseudopancreatic cyst. So most common site of fluid collection, most common site of pseudopancreatic cyst, it is same. What? Lesser sac. It is lesser sac. Another important point, majority of pseudopancreatic cysts are small. And if it is small, you know, patient will be asymptomatic. Patient is asymptomatic. Whenever the cyst is large, it started compressing the stomach. There will be gastric outlet obstruction. So symptom will be, if patient is symptomatic, abdominal pain. Since the cyst is small, it resolves spontaneously, so most cases are managed conservatively. What are the indications of surgery? Guys, you tell me. Tell me in the comment box, indications of surgery. Indications of surgery: first, size more than equal to 6 centimeter, and we have to wait and watch for how many weeks? 6 weeks. So if the duration is more than 6 weeks, duration is more than 6 weeks, in all these cases we have to perform the surgery. Question: which surgery? There are 3 treatment options: cystogastrostomy, cystoduodenostomy, and cystojejunostomy. Cystogastrostomy, cystoduodenostomy, cystojejunostomy. You know which one is most popular? Cystogastrostomy. This is most popular. Whenever cyst is in close relation to stomach, go for cystogastrostomy. And which one is treatment of choice? Cystojejunostomy. So the treatment of choice, it is cystojejunostomy. Okay guys, so see the option. Most common site is lesser sac. This is correct. Most common cause, it is gallstones. No, it is alcohol. This is not gallstone, this is alcohol. Most common symptom, abdominal pain. Correct. Most cases are managed conservatively. So correct answer for this question is B. B, that's the correct answer. Next question, very easy question. You see, first see the image. Guys, you can see the image. Okay, this is barium swallow. Now read the question. A 40-year-old male presented to OPD with dysphagia. Barium swallow. Findings given below. Which of the following statement is not correct? So first, by looking at this image, can you tell me what is the diagnosis? Waiting for your reply, guys. Tell me. Tell me the diagnosis. Krishan Pal Singh Rathore, tell me. What is the diagnosis? Munendra Singh, Vinod Raj, Roopshri, all of you are correct. Tell me the diagnosis. Guys, what is the diagnosis? It's easy question. Yes, Pradyumna Patel, Shri, very good. It is leiomyoma, and all of you know that this leiomyoma is the most common benign tumor of, this is the most common benign tumor of esophagus, leiomyoma. Whenever it is small, patient is asymptomatic, but in this case you can see tumor is large. So what happens? The lumen is compromised, and if lumen is compromised, there is dysphagia. Investigation of choice for diagnosis, it is barium swallow. Why we should not perform endoscopy with biopsy? Because if you perform biopsy, what happens? If you try to do the biopsy, in this case what happens? There will be adhesion between the mucosa and the tumor. Treatment of choice is enucleation. So because of biopsy there will be adhesion, and if you try to perform enucleation, there will be perforation. So endoscopic biopsy, it is contraindicated. This is contraindicated. So it is the most common benign esophageal tumor, correct? Mostly seen in the lower 2/3 of esophagus, correct? Investigation of choice for diagnosis, this is barium swallow. Barium swallow. And what is the treatment of choice? Since it's a benign tumor, easily you can perform enucleation. Now guys, one question for all of you. What are the other tumors in surgery where enucleation is the treatment of choice? Tell me in the comment box. Enucleation is the treatment of choice for which tumor? First, tell me in the comment box. Hemangioma liver. Second, insulinoma, head of pancreas. Insulinoma, head of pancreas. Okay guys. Third, leiomyoma. And fourth, chylolymphatic cyst. Fourth, that is chylolymphatic cyst. So in all these cases, the enucleation is treatment of choice. And another simple principle I want to tell you, enucleation is the treatment of choice for benign tumors. It is not the treatment for malignant tumor. Okay. So majority of you are correct guys for this question. Now see this next one. See the next question. Easy question. Which of the following is not true about Boerhaave syndrome? Waiting for your reply. Tell me guys, what is the correct answer? Boerhaave syndrome. Let me see who is going to reply first. Yes, a little bit tricky question. Waiting for your reply. Shubham, that's not correct. Nobody replied correctly till now. Nobody replied correctly till now. So let me see who is the genius. Who is the genius? Manisha Manju, Prabh Mishra, Rishabh Nayak, Roop Shri, Lakshmi Kush, Vinod Raj. All of you are correct, guys. Let me discuss what is Boerhaave syndrome. In this case, there is spontaneous esophageal perforation, and how this perforation occurs because of repeated vomiting, forceful vomiting. So in this case, what's the problem? You can see here, this is the esophagus. This is the stomach. Because of repeated vomiting, forceful vomiting, there is perforation in the lower 1/3 of esophagus. So whatever the vomitus is there, it enters into the thorax or mediastinum. That's why there is thoracic pain, vomiting, and cervical subcutaneous emphysema. This is known as macular striate. So in Boerhaave syndrome, there is macular striate. What is the location of rupture? This is left posterolateral. It occurs in left posterolateral direction of lower third of esophagus. If you are using barium swallow, in this case, what will happen? See, this is the site of perforation. If you use barium swallow, so barium will enter in this area, mediastinum, and it will cause diagnostic difficulty later because it is going to persist there for very long duration. That's why we are using water soluble contrast, so that this water soluble contrast is absorbed, and that's why it is known as water soluble contrast esophagogram. It is preferred over barium swallow. Which water soluble contrast is preferred? All of you must be knowing. This is gastrographin. What is the name? This is gastrographin. And here the golden period of repair, it is not 6 hours, it is first 24 hours. 6 hours whenever a patient is having some kind of injury. Clear? And whether you have to suture it or not, if it is clean wound, patient comes within 6 hours, suture it. Patient presents after 6 hours, then we have to go for delayed suturing. But here the golden period of repair, it is 24 hours. This is first 24 hours. So correct answer for this question is D. What is the question which is frequently asked in exam? Macular striate. There is thoracic pain, vomiting, cervical subcutaneous emphysema. And what is the investigation of choice? It is not barium swallow, it is water soluble contrast esophagogram. Okay. Tiny World want to ask that, sir, please explain Boerhaave versus Mallory V syndrome. Very good question, Tiny, very good. Have a look. It's very, very easy to understand. Imagine this is esophagus. This is the stomach. Okay. Now see the mechanism of vomiting. Very easy to understand. So here you can see this is the esophagus and this is the stomach. Clear? What is the mechanism of vomiting? When patient is going to do the vomiting, there is contraction of abdominal wall. So abdominal wall is going to contract and it is going to create pressure on the stomach. So what happens when the pressure is created on the stomach? This LES is going to open, lower esophageal sphincter is going to relax, glottis is going to relax, and the vomitus comes out. Imagine some alcoholic patient is there and there is incoordination in the reflexes. So LES is going to relax but glottis is not going to relax. So there will be very high pressure in the esophagus, and because of very high pressure, esophagus is going to perforate in the lower 1/3 along left posterolateral direction. So what will happen here? You can see there is longitudinal tear. So longitudinal perforation occurs in esophagus. This is known as Boerhaave syndrome. Whenever LES is not going to relax properly, timely, there is high pressure in stomach. So there will be longitudinal tear at cardia. just below GE junction. So if longitudinal tear occurs at cardia, this is known as Mallory-Weiss syndrome. So Mallory-Weiss syndrome, in this case there is tear at cardia just below GE junction. Clear? And what happens in Boerhaave syndrome? There is longitudinal tear or perforation in the lower third of esophagus. Okay, so tiny world, I hope the confusion is clear now. Boerhaave syndrome, it is the condition of esophagus, and Mallory-Weiss syndrome, it is the condition of stomach. In Mallory-Weiss syndrome, there can be bleeding also, but massive bleeding occurs only in 20% patients. Okay, now guys, let's see the next question. Next question. Let me see who is going to reply correctly. "50-year-old female, 50 years, brought to medicine OPD with anemia. There is anemia. Endoscopic finding is given below. Which of the following statement is incorrect?" Let me see who is going to reply this correctly. Let me see who is going to reply correctly. Guys, tell me. Yes, very good. Dr. Naruto, Dr. Ankit Gujjar. Okay. Somebody wants to ask Dr. Adenocarcinoma, sir, Haman crunch specific for Boerhaave? No. Haman crunch, it is not specific. It is seen in pneumomediastinum. In Boerhaave syndrome also there is pneumomediastinum. It can be seen in any condition in which there is pneumomediastinum. Okay guys, so all of you know what is this? This is watermelon stomach. Guys, can you tell me what is the other name of this watermelon stomach? What is the other name of this watermelon stomach? Yes, you know this is also known as GAVE. Other name is GAVE. GAVE means this is gastric antral vascular ectasia. Very easy to understand. So this is what? Gastric antral vascular ectasia. All of you know that the answers are hidden here. First, what is the pathology in this case? Vascular ectasia. What is the most common site? Antrum. It looks like watermelon, on which investigation, if you perform endoscopy, you can see there is parallel stripes of dilated vessels. So parallel stripes of dilated vessels, it looks like watermelon, rind of watermelon. So that's why it is known as watermelon stomach. What is the problem here? Pathology is vascular ectasia. So there are dilated mucosal blood vessels in lamina propria. Because of these dilated vessels, what's the problem? There is bleeding. And if these patients will be having bleeding, what is the manifestation? There is occult bleeding. And because of occult bleeding, the patient will be having anemia. And because of this anemia, what is the symptom? Symptom is fatigue. Symptom is fatigue. How we are going to make the diagnosis? It's easy. What you do? You perform endoscopy. On endoscopy, there will be dilated vessels, which looks like parallel dilated vessels, looks like rind or covering of watermelon. And if you perform biopsy, there is presence of vascular ectasia. So diagnosis is made on, or diagnosis is done by typical endoscopic and biopsy appearance. Clear? So let's see the question. Dilated blood vessels in lamina propria, correct. Bleeding is the most common presentation, correct. Diagnosis is based on typical endoscopic and biopsy appearance, correct. So none of the above. All three are correct. So D is the correct answer, none of the above. Guys, let me tell you a simple clue, simple logic. Whenever you are solving MCQs or going to appear for any kind of exam, all of the above, it is commonly correct. None of the above, it is rarely correct. So until and unless you are 100% sure then only mark none of the above. Otherwise, it has been seen that in MCQs, none of the above, it's rarely correct. So if you are not 100% sure, don't mark none of the above. Clear? But here, none of the above, that is correct answer. And Manisha Manju, you are correct. We treat it by argon photocoagulation or plasma coagulation. We can go for endoscopic electrocoagulation also. Okay. Now see the next question. Very, very important question. It was asked many times. Let me see who is going to mark this question correctly. All of the following statements are correct about GIST except. Guys, tell me what is the correct answer? Yes, let me see who is going to reply correctly. Easy question. GIST, gastrointestinal stromal tumor. Tell me what is the correct answer here? Adenocarcinoma, Ankit Gurjar, Roopshri, Lakshmi Kush, Manisha Manju, Ankit Pindaria, all of you are correct, guys. Brijlesh Yadav, all of you are correct. So GIST, what is the full form? Gastrointestinal stromal tumor. This is gastrointestinal stromal tumor. Clear? You know the most common site of GIST, it is stomach. What is the most common site? This is stomach. You know it is positive for CD117. There is a triad. What is the triad name? Carney's triad. And what are the components of Carney's triad? Extra-adrenal paraganglioma, pulmonary chondroma and multifocal GIST. What is the investigation of choice? Have a look. This is the stomach. If you see the tumor grows like this. The growth of tumor is outside the lumen. So this is extraluminal, and you know that intra-abdominal condition, in abdomen, extraluminal conditions of GIT are best diagnosed by CCT. So here the investigation of choice for diagnosis, it is CCT. It is not endoscopy with biopsy. It is CCT. And if you see the management, what we go for? Wedge shaped excision. Can you see here, guys? The name is GIST, gastrointestinal stromal tumor. Since the tumor is arising from stroma, so it behaves like sarcoma. And in sarcoma, what is sufficient? Wide local excision. So here we go for wedge. What kind of treatment? We go for wedge shaped excision. We go for wedge shaped excision. And how much margin we take? We take 2 centimeter margin. So wedge shaped excision, we take 2 centimeter margin. Imagine it is unresectable tumor. So all of you know, if the tumor is unresectable, what is the first line agent? Guys, imatinib. What is the second line agent? Sunitinib. And what is the third line agent? Regorafenib. Clear? So first line agent, you know, first line agent, this is imatinib. Imatinib. All of you know what is the second line agent? Second line agent, this is sunitinib. Sunitinib. And what is the third line agent? Third line agent, that is regorafenib. Third line agent, this is regorafenib. Clear? So correct answer here. D is also correct. Regorafenib, it's the third line therapy in patients failing imatinib and sunitinib. So correct answer is C, because investigation of choice for diagnosis, it is not endoscopy with biopsy, it is CCT. And let me tell you, endoscopic biopsy is contraindicated. Why it is contraindicated? Because tumor is hypervascular. So if you are going to perform endoscopic biopsy, tumor might rupture. So endoscopic biopsy, it's contraindicated. Endoscopic biopsy, it is contraindicated because it might cause tumor rupture. Clear? So correct answer for this question is C. Now guys, it's very, very easy question. Integrated question, very, very easy question. Tell me what is the correct answer here. Read the question. Infant after 4 weeks of birth was brought with the history of multiple episodes of non-bilious vomiting. Non-bilious projectile vomiting. X-ray abdomen was done. Condition is associated with. First see this X-ray. if you see this X-ray carefully, there is a single bubble. Can you see here, guys? This is single bubble. And what is this single bubble actually? This is the stomach which is distended. This is the whole stomach which is distended. Clear, guys? So this is single bubble. Now can you tell me what is the correct answer? Waiting for your reply. Yes, Harsh Kasholia, Meet, Humble Doctor, Adenocarcinoma, Pradyumna Patel, Vijay Kumar, Jyotiwal, Shri, very good. All of you are correct, guys. So this is hypertrophic pyloric stenosis, and all of you know what kind of dyselectrolytemia is seen. Have a look. Imagine this is the stomach. See, this is the stomach. Here there is hypertrophic pyloric stenosis. Clear? So obstruction is here. Because of this, in the gastric juice, can you tell me what is the component? Component of gastric juice, HCl, and it is rich in potassium. So if patient is having multiple episodes of vomiting, there is a loss of H plus, means metabolic alkalosis. There is metabolic alkalosis. Chloride, so hypochloremia. What will happen? There is hypochloremia. And what else? There is hypokalemia. Hypokalemia. So there is hypokalemia, hypochloremia, metabolic alkalosis. Clear? So what is the correct answer here? Hypochloremia, hypokalemia, metabolic alkalosis. And there is another manifestation these patients are having, paradoxical aciduria. So hypokalemia, hypochloremia, metabolic alkalosis with paradoxical aciduria. There is paradoxical aciduria. Okay, guys? Correct answer is A. Now see this next question, very easy question. Tell me what is the correct answer here. Simple. While doing emergency laparotomy for intestinal obstruction, which organ would you first visualize to say whether it is small bowel or large bowel obstruction? Which organ would you visualize to say it is large bowel or small bowel obstruction? Tell me, guys, what is the correct answer? Yes, let me see. Love Pandey, Naruto, Harsh Karodia, Tiny World, Vijay Kumar, Munendra Singh, Gujjar, Atul Saini, all of you are correct. Now it's very easy to remember. Have a look. Imagine this is the bowel. This is the bowel. Imagine here is the obstruction. So any luminal structure is there, tubular structure is there, like ureter, like bile duct, like bowel. So whenever obstruction is there, the distal part will be collapsed and the proximal part will be distended. So this is how we are going to determine the site of obstruction. Okay. Now you know here, suppose this is small intestine. If small intestinal obstruction is there anywhere, there is obstruction in the small intestine anywhere. Clear? So if small intestinal obstruction will be there, obviously what will happen? The proximal part will be distended. You can see here. The proximal part will be distended, but distal part will be collapsed, means the large intestine will be collapsed. Whenever there is large bowel obstruction, obviously cecum will be distended and the distal part will be collapsed. So imagine here is the obstruction in large intestine. So what will happen? This part will be distended, distal part will be collapsed. So what is the landmark? It is cecum. If a patient is having what? Small bowel obstruction, cecum will always be collapsed. And if a patient is having large bowel obstruction, cecum will always be distended. So whenever we are going to open the abdomen in patients of intestinal obstruction, the first organ which we visualize, that is cecum. If it is distended, we know that there is large bowel obstruction. If it is collapsed, we know that it is small bowel obstruction. So it was asked in one of the latest exam, and what is the correct answer? Cecum. Most of you were correct for this question. Now see the next one. Easiest question. Guys, tell me what is the correct answer here. Easiest. A multi-para patient brought to the emergency with signs and symptoms of small bowel obstruction. After resuscitation, X-ray was performed X-ray findings are given below. Most probable diagnosis. Let me check how many of you are correct. Yes. Love Pandey, Roshan Bhatia, Tiny World, Shri, Naruto. Guys, this question I included. Why? Because I know that you people are obsessed with what? Sigmoid volvulus. So everything you look that appears like what? Coffee bean. Have a look how coffee bean looks like first. You can see here. So here you can see how this coffee bean looks like. So see this image first. So in this image you can see this is how coffee bean looks like. This is how coffee bean looks like. Clear? And if you see this image, this is not coffee bean, this is kidney bean. This is not coffee bean, this is kidney bean, and this kidney bean sign is seen in cecal volvulus. It is not seen in sigmoid volvulus. So you have to be careful. Yes, this is actually cecal volvulus. In sigmoid volvulus, this is coffee bean, and this sign is known as, you can see here, this is known as kidney bean. There is kidney bean sign. There is also another sign which is seen, comma shaped cecum. Comma shaped cecum. Clear, guys? So this question is very, very important. Whenever this question is asked in exam, you can't believe 90% students are going to mark what? Sigmoid volvulus. Why? Because they are obsessed. So everything they see, they think that this is what? This is coffee bean. Actually, this is kidney bean. So correct answer for this question is D. Okay. Bhari mistake ho gayi, sir. Very good. Adenocarcinoma. Doesn't matter. I want that you should do the mistake here so that in exam you are going to give the result with flying colors, guys. Now, next question. Very, very easy. Tell me what is the correct answer. 26 years old male. 4-day history of pain in right sided lower abdomen. Frequent vomiting. Patient general condition is fair. Tender lump where? Right iliac fossa. Most appropriate management for this case would be easiest question. Easiest question, guys. This is the easiest question. Lakshmi Kos, Rohan Bhatia, Shri, Yogesh Dama, Naruto, Bharat Patel, Vinod, all of you are correct. So you know here there is pain where? Right lower abdomen, vomiting, and there is lump. So pain is there, vomiting is there, and in right iliac fossa there is lump. So what could be this lump? This kind of acute history with lump is there. It means this is appendicular lump. And whenever there is appendicular lump, you know that we have to manage this lump conservatively. And by which regime or by which regimen we have to perform the management? Oshner-Sherin regime. So exploratory laparotomy, it is only done when there is perforation. It's done when there is appendicular perforation. Appendectomy is done when there is no lump. Appendicitis is there. External drainage is there when there is pus collection. So correct answer here, Oshner's-Sherin regime. This is appendicular lump. So we perform Oshner's-Sherin regime. Okay, guys, correct answer is C. Next, all of the following statements are correct about landmarks in laparoscopic repair of inguinal hernia except. Let me see who is going to reply this question correctly. Or let us discuss this question directly. First, let me tell you what is triangle of doom, triangle of pain. See this, focus here. Triangle of doom. So medially, you can see in triangle of doom there is vas deferens or ductus deferens. Laterally, gonadal vessels. Apex is formed by deep ring. Base by peritoneal edge, and the content is iliac vessels. Clear? So you can see here first, triangle of doom bounded laterally by gonadal vessels. This is correct. Okay. Now see triangle of pain. In this triangle of pain, you can see there are 4 nerves. See the boundaries first. Medially, there is gonadal vessels. Superiorly, you can see here, superiorly there is iliopubic tract. and laterally there is peritoneum. There are 4 nerves. If you see, first there is femoral nerve, then femoral branch of genitofemoral nerve, then anterior cutaneous nerve of thigh and lateral cutaneous nerve of thigh. Why it is known as triangle of pain? In this area, we are not supposed to use the electrocautery. Use of electrocautery will injure the nerves and it leads to pain in the post-operative period. Another question which is asked frequently, which nerve is most commonly injured in laparoscopic hernia repair? And the most commonly injured nerve, that is lateral cutaneous nerve of thigh. Lateral cutaneous nerve of thigh, this is most commonly injured. So now see the option, most commonly injured nerve in triangle of pain, lateral cutaneous nerve of thigh, correct? Triangle of pain is bounded superiorly by, yes, iliopubic tract. It is bounded superiorly by iliopubic tract. The third landmark, it is corona mortis, also known as crown of death. So in this corona mortis you see, this is inferior epigastric artery, which is the branch of external iliac. It's a branch of external iliac. This is obturator artery, it's a branch of internal iliac. There is aberrant obturator artery, also known as corona mortis artery, arises from inferior epigastric, attaches to obturator. This is injured during mesh fixation leading to bleeding and death. That's why it is known as crown of death or corona mortis. Clear? So see the option. Aberrant obturator artery, it's responsible for bleeding. It's responsible for bleeding in corona mortis, correct? So A is correct, B is correct, C is correct, D is incorrect, because you know that triangle of pain, it is bounded superiorly by iliopubic tract. It is not bounded by peritoneum. Clear guys? So correct answer is D. D. Clear? Now see this. Easiest question, tell me guys, what is the most common complication of splenectomy? Easiest question. Yes. Easiest question. Dr. Naruto, most common complication of splenectomy. Shri Harry 42, very good. Rohan Bhatia, most of the times you are correct. Humble Doctor, Roopshri, you are also correct most of the times. Roopshri. Guys, this is very common mistake you do in exam. OPSI, it is not the most common complication of splenectomy. It is most common late and fatal complication. Late means it is going to occur after 2 to 5 years. Clear? So this is not seen in immediate post-operative period. This is most common late and fatal complication. Late and fatal complication. After how many years it is seen? Usually seen after 2 to 5 years. After 2 to 5 years. Clear? What is the most common complication? What happens when you perform the splenectomy? There is injury to some fibers of diaphragm. So patient is having restricted movement of diaphragm during respiration. So what happens? There is collapse of left lung, that is known as atelectasis. You have to remember, most common complication of splenectomy, this is atelectasis. So it's the atelectasis which is the most common complication. If atelectasis is not given in the option, then choose what? Pancreatitis, because you know the tail of pancreas, it is in close relation to spleen. So during dissection you might injure the tail of pancreas. It can cause injury or it can cause pancreatitis. So correct answer is D. OPSI, it is the most common late and fatal complication. Now this is easiest question. It was asked at least 50 to 60 times. I want 100% correct answer. Guys, tell me what is the correct answer. Tell me what is the correct answer for this question. Dr. Naruto, Khushbu, Lakshmi, Rohan Bhatia, Brijlesh, Khushbu, Vinod Raj, everybody is correct. You know this is uretrocele. What happens here? In this image you can see what is the name of this sign. This is adder head or cobra head appearance. So what is the name? This is adder head or cobra head appearance. This is adder head or cobra head appearance. Clear? And it is seen in uretrocele. In this case, you can see there is bilateral uretrocele, bilateral hydrouretronephrosis. So, what is the correct answer? B, uretrocele. Another very, very easy question. It's an integrated question, guys. Tell me what is the correct answer. Have a look. After road traffic accident, patient was brought to the emergency, diagnosed to have pelvic fracture, difficulty in passing urine and hematuria. CT cystography given below. What is the preferred surgical treatment apart from pelvic fracture management? First, you tell me what kind of bladder rupture is this? This is intraperitoneal or extraperitoneal? Guys, tell me which one? This is intraperitoneal or extraperitoneal? Bladder rupture. Let me see who is the genius. Yes. Guys, it's very, very easy question. Pelvic fracture is there. So, because of pelvic fracture, which kind of injury? Bharat Patel, first person to reply. It is extraperitoneal. Varun Kashyap, it is extraperitoneal bladder rupture. Can you tell me the name of this sign? Easily you can make out. This is flame sign. Can you see, guys? This is flame sign. What kind of rupture? This is extraperitoneal bladder rupture. And what is the cause of this extraperitoneal bladder rupture? Pelvic fracture. So, let me explain. If there is, this is the bladder, because of pelvic fracture, what happens? There is tear. So, here there is tear, and because of tear, what happens? There is extravasation of contrast. So, after pelvic fracture management, don't do anything. What you do? You just insert Foley's. Insert the Foley's catheter. What will happen? The margins are going to oppose each other, and within 7 to 10 days, it is going to heal spontaneously. So, nothing should be done, only Foley's catheterization. This is extraperitoneal bladder rupture, nothing should be done, only Foley's catheterization after pelvic fracture management, and it is going to heal. In which cases we are going for laparotomy? Whenever there is repeated occlusion of catheter, there is tear near neck of bladder, or there is bony fragment impinging on the bladder wall. Clear? Let me tell you, when patient is having urethral injury, then you go for SPC. Suprapubic cystostomy, it is done whenever, this is gold standard treatment, whenever we suspect urethral injury. This is bladder rupture. Here we go for Foley's catheterization. And imagine it is intraperitoneal bladder rupture. Because of that, there will be extravasation of urine within the peritoneal cavity. In that case, we will go for what? We will go for laparotomy. Clear, guys? So, what is the correct answer here? It is Foley's catheterization. Okay, Love Pandey, it is Foley's catheterization. Okay, this is the latest question. It was asked in a latest exam. After varicocele surgery, venous drainage of testis occurs by. Tell me, guys, easiest question. Easiest. After varicocele surgery, venous drainage of testis occurs by. All of you are correct. It's a repeat question. Cremasteric veins. Cremasteric veins. Correct answer is cremasteric veins. Clear? See what happens here. Have a look. This is varicocele, dilated tortuous pampaniform plexus of veins. So, what we do? We can ligate this vein in the retroperitoneum. This is known as Palomo's operation. Or we can ligate it close to the deep ring. This is known as high inguinal ligation. Near deep ring, this is known as high inguinal ligation. Or you can ligate it close to the testis below-inguinal ligament, microvascular subinguinal ligation. So, if you ligate the gonadal vein or testicular vein, there should be alternative venous drainage channel. And what is that? Alternative venous drainage channel, that is cremasteric veins. Alternative venous drainage channel, that is what? Cremasteric veins. So, correct answer is cremasteric veins. Okay, guys, all of you were correct. That was cremasteric veins. Clear? Now, very, very easy question. Let me see who is going to reply correctly and fastest. Okay, all of the following statements are true about peripheral arterial occlusion except. Waiting for your reply, guys. Tell me, what is the correct answer? Yes, nobody replied correctly yet. Nobody replied correctly till the point. First person to reply correctly, Manisha Manju, Bharat Patel. Two people, Manisha Manju, Bharat Patel, Shri, Varun Kashyap, Dr. Naruto, Rishabh Nayak. Guys, all of you are correct. Now let's check. Peripheral arterial occlusion, what is the most common cause? In artery, the most common cause of occlusion, it is atherosclerosis. The most common cause of occlusion, atherosclerosis. Okay, or atheroma. Second, in young male smokers, it can also caused by Burgess disease. So Burgess disease is also a cause, but the most common cause, that is atherosclerosis. Clear? Now, what happens whenever there is peripheral arterial occlusion? Whenever a muscle group is doing work or exercise, then there is intermittent claudication or pain. So obviously, the pain will occur during work or exercise. Clear? But there is rest pain. When patient is relaxing, patient is resting, rest pain is there. It is because of cutaneous ischemia. Okay? Now imagine a patient is having obstruction at aortoiliac bifurcation. So just below that, all muscle groups will be having intermittent claudication. It means depending upon the site of obstruction, you can have a typical clinical picture. So see, rest pain, it is seen at night, correct? Pain of intermittent claudication starts on taking the first step when muscle starts doing work or exercise. Atheroma, it is the most common cause, correct? Clinical picture does not, no, clinical picture reflects the site of peripheral arterial obstruction. So D is incorrect and this is the correct answer. Correct answer is D. Okay guys, now tell me what is the correct answer for this question, guys. I'm waiting for your reply. Waiting for your reply. All of the following statement is correct about burns, its management, except. Let me see who is the genius over here. Let me see what is the correct answer here. Guys, tell me. Munendra Singh Gujjar. Very good, Munendra. Naruto, Rao Saab, Lakshmi Khush, Roop Shri, Harsh Kashodia. Majority of you are correct and you know the simple concept. Have a look. What happens? Most common cause of early death in burns, you know, it is hypovolemia or shock. So that is correct. Best clinical indicator of tissue perfusion, that is urine output, correct. Maintenance fluid of choice, be careful, it is maintenance fluid of choice in burns in children. It is not ringer lactate, it is DNS. Dextrose normal saline, the fluid of choice in burns in the patient of burns, ringer lactate, but maintenance fluid of choice in children, it is dextrose normal saline. Why? Because children are having very little glycogen reserve. That's why for maintenance we have to add dextrose. And if patient is having pseudomonas infection, we give silver sulfadiazine, which is effective. So A, B, D are correct, C is incorrect. Correct answer for this question is C. Okay guys, C is the correct answer. Easiest question, which of the following statement is correct about fast? Easiest question, guys, tell me. Medivision doc, adults may DNS we are not giving. Why? Because adults have sufficient glycogen reserve. So for maintenance also ringer lactate is given. No need to give DNS separately. Yes, correct. All of you are correct, guys. All of you. You know, FAST is focused assessment with sonography for trauma. It is done in 2 to 4 minutes. First investigation done in blunt trauma abdomen. So all these are correct. Correct answer is D. D. So what we do here, you can see in this image, very, very easy. There are 4 views. There is what we assess: pericardial sac, perihepatic region, perisplenic region and pelvis, and in this sequence. So how to remember? We are going to assess 4 P's and how many minutes? 4 minutes. So 4 P's, 4 minutes. So within 2 to 4 minutes, we are going to assess pericardial sac, perihepatic region, perisplenic region and pelvis. There is E-fast, and all of you know in E-fast, which is known as extended fast, we add right thoracic and left thoracic view. And if you perform E-fast, on E-fast, if patient is having pneumothorax, there is stratosphere sign. What happens? Patient is having stratosphere sign, also known as barcode sign. So there is stratosphere sign or barcode sign. Clear? Important points related to fast. You know, first investigation done in patients of blunt trauma abdomen, that is fast, and it is done both in stable as well as unstable patient. If patient is unstable, we take the patient for exploratory laparotomy, and if fast is positive, patient is stable, we take this patient for CCT to confirm the findings. Clear, guys? So next question, very easy. All of the following are part of asepsis wound score. Southampton wound grading and asepsis wound score are very important, except, let me see. Okay, Rao Saab wants to ask about Caroli's disease. What is Caroli's disease? It is type 5 choledochal cyst. Caroli's disease, that is type 5 choledochal cyst. And what is the problem here? See, in Caroli's disease, there are multiple cysts only in the intrahepatic part of bile duct. And if you perform CT, there is central dot sign. Central dot sign. So I am repeating, Caroli's disease, it is type 5 choledochal cyst in which multiple cysts are there involving only intrahepatic bile duct. There is central dot sign. Okay, guys. So what is the correct answer here? All of you are correct, guys. All of you. It is induration. In asepsis, this is the mnemonic also, and here I means isolation of bacteria from the wound, not the induration. So serous discharge is there, purulent exudate is there, erythema is there. So correct answer is C. Now see here, asepsis wound score. What is A? Additional treatment. S. Serous discharge. E. Erythema. P. Purulent exudate. S. Separation of deep tissues. I was not in induration. Isolation of bacteria from the wound, and S, that's stay as inpatient prolonged over 14 days as a result of wound infection. So stage is prolonged over 14 days as a result of wound infection. So this is asepsis, and you can see mnemonic is also asepsis. Clear? You have to remember Southampton wound grading and asepsis score. Okay? Easiest question, it was asked minimum 20 to 30 times in exam. So many clues are there. Tell me what is the correct answer for this question, guys. Tell me. 28 years old patient brought to the emergency after severe road traffic accident. Attending clinician found the fracture of right femur. Initially he was alert, conscious, oriented, but after 12 hours confused, developed breathing difficulty, skin rashes in axilla and chest. What is the cause? Yes, all of you are correct. All of you. Very good. Divya, Roopshri, Yogesh, Dama, Tiny World, Vasisht, all of you. See, whenever any patient in whom there is history of long bone fracture, clue, history of long bone fracture. Initially patient is all right, but with after 24 to 48 hours, when patient becomes, consciousness is impaired consciousness, so patient is confused. Patient is having breathlessness or dyspnea. And most characteristic features that these patients are going to develop rashes or petechiae, where in axilla, in chest, in conjunctiva or in retina. So presence of rashes or petechiae, this is characteristic. So it is seen in fat embolism. Correct answer for this question, it is fat embolism. Next question, guys, tell me, very easy and frequently asked in exam, frequently. 4 hours before visiting casualty, patient hit his leg. On examination, pain on passive stretching and distal pulses were palpable. What is the most probable diagnosis? Tell me. Easy question. Tell me guys, what is the most probable diagnosis? All of you are correct. All of you, everybody is correct. Compartment syndrome. Because only in compartment syndrome there is pain on passive stretching. Why? Because there is ischemia. What is compartment syndrome? In one of the compartment there is increased pressure more than 30 mmHg, and it is going to what? Impair the perfusion. So because of this muscle ischemia, there is pain on passive stretching. There is severe pain. Pulses are palpable. Absence of distal pulses, it's a late sign. Clear? And what is how you are going to make the diagnosis? Measure the compartment pressure. If it's more than 30, patient is having compartment syndrome, we perform fasciotomy. So here what is the correct answer? This is compartment syndrome. In necrotizing fasciitis, what happens? Within 4 hours necrosis doesn't occur, and here there is blackish discoloration. Blackish discoloration. In Burgess disease, there is no relation of trauma. DVT, it is not related to trauma, and here these patients are going to develop edema. Edema. So correct answer is what? Compartment syndrome. Okay guys, so this is compartment syndrome. Now easiest question, let me tell you, in this question all the ATLS modifications related to trauma are included. So which of the following are not included in latest ATLS modification? Let me see who is the genius who is going to reply this question correctly. Waiting for your reply guys, waiting. Waiting for your reply. Yes. Munendra Singh Gujjar. Very good. The trophy goes to Munendra Singh Gujjar. Then Medivision Doc. Harry 42. Ankit Pindaria. Very good. Dr. Naruto. Guys, majority of you are correct. Let's discuss all the ATLS modifications related to trauma. Nowadays, according to ATLS modification for intubation, we should use video laryngoscope. So use of video laryngoscope for intubation. This is the latest update. Insertion of wide bore needle in 5th intercostal space in adults. Initially it was said that it should be in 2nd intercostal space, but in children it is 2nd intercostal space in mid-clavicular line, and in adults it is 5th intercostal space in anterior axillary line or slightly anterior to mid-axillary line. So this is correct. Give only 1 to 2 liters of warm isotonic crystalloids for adults having shock. No, previously 1 to 2 liters was given, but now only 1 liter. This you have to remember, this was asked in AIMS and INICT. Any patient who is having shock, we have to give 1 liter of warm isotonic crystalloid. And in children with shock, initially we give bolus of 20 ml per kg, followed by 10 to 20 ml per kg of packed cell, plasma and platelets, and according to trauma transfusion protocol, in which ratio packed cell, plasma and platelets are given in the ratio of 1:1:1. So ratio is how much? 1:1:1. Clear guys? So this is very, very important. Correct answer is C. Previously we were giving 1 to 2 liters of warm isotonic crystalloids, but now we are giving only 1 liter. This is the update. Another question, easiest question, management of flail chest with respiratory failure. Tell me what is the correct answer. Flail chest with respiratory failure, easiest question. Vinod Raj, Bharat Patel, Divya, everybody is correct, because you know that in flail chest with respiratory failure, we go for intermittent positive pressure ventilation. This is intermittent positive pressure ventilation. And you know what is the definition of flail chest? When 2 or more than 2 ribs, consecutive ribs, fractured at 2 or more than 2 places. So there will be one part of chest wall which is isolated. Clear? if there is no respiratory failure, we just give analgesia, oxygen supplementation and physiotherapy. But if there is respiratory failure, we go for intermittent positive pressure ventilation. Clear guys? So correct answer is C. Easiest question, it was asked many times in exam. Which of the following is least commonly used graft in CABG? First you tell me what is the most commonly used graft? Most commonly used graft. You know the most commonly used that is long saphenous vein. Which one is most preferred? The most preferred, it is Lima. Lima. This is left internal mammary artery. Lima, most preferred. Why? Because this is arterial graft. Radial artery can also be used, but intercostal arteries are not used. So this is least commonly used, intercostal artery. So you have to remember, most preferred Lima, most commonly used long saphenous vein, intercostal arteries rarely or least commonly used. So here you can see the image. Correct answer is D. And you can see this image. So in this image you can see that we are using here long saphenous vein. In this image you can see that internal mammary artery is also used. Here you can see radial artery is also used, but intercostal artery is rarely used. Rarely used. Okay guys. Next, very easy and frequently asked repeat question. Tell me what is the correct answer for this question. Easiest question guys, tell me. This is the typical history. So only on the basis of this CT, NCCT, you can make the diagnosis. Elderly patient fell in the bathroom, early morning hours, rushed to the casualty. GCS is impaired, 9/15, urgent NCCT. Comment on the diagnosis. You can see here what kind of appearance. So you can see here there is concavo-convex hyperdense lesion. Concavo-convex, and this concavo-convex hyperdense lesion, it is because of STH, subdural hematoma or subdural hemorrhage. Now what is the difference between EDH and STH? You can see here, very easy to understand. Extradural. So this is because of injury to which artery? Middle meningeal artery. Whenever there is this pterion, which is the weakest part of skull, it is injured. Because of that there is injury of middle meningeal artery. So there is arterial bleeding. Here dura is peeled off. Clear? What happens in STH, subdural hematoma? It is because of injury of cortical veins or bridging veins. But here dura is still attached. So if you see the NCCT, here there is biconvex lesion and here concavo-convex lesion. In EDH, which interval is positive? Lucid interval. Lucid interval is positive, and both of these cases are drained by burr hole, and if large hematoma is there, we can go for what? Craniotomy. So large hematoma is there, we can go for craniotomy. So you have to remember, let me tell you, every year there is one question related to tension pneumothorax, there is one X-ray showing perforation peritonitis, one NCCT will be here given, this one EDH or STH. So correct answer, it is B, subdural hemorrhage or hematoma. Another question guys, another easy question. Tell me, what is the optimal timing of administration of prophylactic antibiotics? Best time to give prophylactic antibiotics. Ragnar, I love you too. Rohan Bhatia, yes? Tell me guys. Yes, this is very tricky question, so read the question carefully. You are very prone to do the mistake, and I can see majority of you are doing the mistake. Majority of you are doing the mistake. Naruto, Shri, Tiny World, Naruto, Shri, Tiny World. Yes, these are the people who are correct most of the times. Shri, yes. Guys, what is the best time? See, it should be given at the time of induction or 1 hour before surgery. What you have to remember? Best time to give? At induction of anesthesia. Induction of anesthesia. Or 1 hour before surgery. 1 hour before surgery. Clear? So correct answer is at induction of anesthesia. Any time during surgical procedure, no. 1 hour after induction, no. 1 hour prior to induction of anesthesia, no. So that's why you have to remember. Clear? So what? It is at induction of anesthesia or 1 hour before surgery. Clear? So read the question options carefully and then mark the correct answer. Okay guys, Sayani Bhattacharya, you are correct. Another very easy question guys. Which of the following is used as preservative? Preservative for packing cat gut. You know, cat gut is the sheep gut. Which layer? Sheep's ileum. Cat gut is prepared from sheep's ileum. And which layer? Submucosa. It is prepared from sheep's ileum, submucosa, absorbable suture, absorbed in 60 days. But it is sheep's ileum. If you will not use preservative, it will be destroyed by bacteria. That's why we are using a preservative. Majority of you are not correct. Rao, Ragnar, Roopshri, Love, Pandey. Yes, it is isopropyl alcohol. Clear guys? So what is the preservative? Isopropyl alcohol is the preservative for packing catgut sutures. So you have to remember the sutures. Catgut absorbed in 60 days. Which sutures are absorbed in 60 to 90 days? Mnemonic is VCD. Full form, it is Vicryl, chromic catgut, Vicryl, chromic catgut, and Dexan. Dexan is polyglycolic acid. After that, 120 days, 90 to 120 days, this is monocryl. Monocryl. That is also known as polyglycaprone. Polyglycaprone. Clear guys? And which suture is absorbed in 180 days? 180 days. Which suture is absorbed? Tell me guys. It is PDS. And what is the full form? Polydioxanone. So PDS is absorbed in 180 days. That is polydioxanone. These are very important questions. You have to remember the days, that in how many days these sutures are absorbed. Clear? How many days these sutures are absorbed? PDS, that is polydioxanone. This is polydioxanone. Clear? Okay guys, next question. What is the name of given instrument? Easiest question. See the instrument. This instrument is having a slot. Here you can see there is a slot. And what kind of serrations are there? There are crisscross serrations. If you can see here, this kind of serrations are there. Crisscross serrations. So what is the name of this instrument? Yes, majority of you are correct. Everybody is correct. Okay, everybody, all of you are correct guys. This is needle holder. So how to identify a needle holder? There is a slot for the needle and there are crisscross serrations. Crisscross serrations. Okay, crisscross serrations. Now how to differentiate it from other instruments? Have a look. First, how to differentiate it from artery forceps? So if you see the artery forceps, in artery forceps, what kind of serrations are there? Transverse serrations. Transverse serrations are there in artery forceps. And how to differentiate it from Cocker's forceps? In Cocker's forceps, there is a tooth and groove. Here you can see. In this image, you can see there is a tooth and groove. So there is a tooth and groove in Cocker's forceps. Now, how to differentiate it from tooth forceps? Here you can see the tooth forceps or tissue forceps. Again, it is having a tooth and groove. And if it is plain forceps, it is having transverse serrations. Clear? So this is what? This is the artery forceps. This is the needle holder. In artery forceps, what kind of serrations are there? There are transverse serrations. In Cocker's forceps, there is tooth and groove. Tooth and groove. Clear? Another question is asked. Suppose this is the needle and here the suture is attached. Right? So tell me where we are going to hold the needle with needle holder. Where we are supposed to hold the needle with needle holder? At the junction of 2/3 from needle end, from tip, and 1/3 from swaged end where suture is attached to the, where the needle is attached to the suture. So this is the point where we are going to hold the needle at the junction of 2/3 from pointed end and 1/3 from the swaged end. What is the swaged end? The end where the suture is attached. So this is where we are supposed to hold the needle with the help of needle holder. Clear? So guys, these were the important questions, expected questions in FMG. I hope that your preparation is going on nicely. All of you are studying really very hard. The best wishes are with all of you. We hope that you are going to crack this exam with flying colors. So best of luck. Keep studying. Thank you very much for this kind of interaction.